The following podcast is part of a certified educational activity titled Stepping Stones on the Path to a Healthier Future for Patients with Primary Hyperoxaluria Type 1, Expert Perspectives on Ensuring Timely Diagnosis and Appropriate Management. Access the entire activity and complete the post-test at peerview.com/EZY860. Downloadable slides and practice aids are also available.
Hello, this is John Liskey from the Mayo Clinic in Rochester, Minnesota. Welcome to this educational activity titled Stepping Stones on the Path to a Healthier Future for Patients with Primary Hyperoxaluria Type 1, Expert Perspectives on Ensuring Timely Diagnosis and Appropriate Treatment. Joining me today in this discussion is Dr. Matthew Briggeman from UCSF Health. Welcome, Matthew.
Thank you, Dr. Liskey. Glad to be here.
Our goals for today's sessions are, as listed here, to improve your understanding of the prevalence, pathophysiology, clinical features, symptomatology, consequences, and disease burden associated with PH1, enhance your ability to apply the latest guideline recommendations to diagnose PH1 early, and refer patients as appropriate to specialized nephrology care for targeted treatment, and to provide you with an understanding of the mechanisms of action, efficacy, safety, and ability of current and emerging strategies to prevent the decline of kidney function and systemic complications in patients with PH1. So with that, I'll turn it over to Dr. Briggeman. Take it away.
Thanks. Yes, we thought we would start off with a patient case. So Sarah's an 11-year-old who's had recurrent urinary tract infections over the past 4 years. She has also had 2 prior episodes of kidney stones starting at age 5. And both of these episodes required hospitalization for pain management and for surgical stone removal. She doesn't have any family history of kidney disease or any family history of hyperoxaluria. And Sarah's now presenting to your clinic with a 2-week history of flank pain, hematuria, and dysuria. Her parents also report that she has been unusually fatigued and has had decreased appetite over the past month. She's had 3 episodes of urinary tract infections in the past year, and these 3 episodes are treated by her primary care provider with antibiotics. Her flank pain over the last 2 weeks has been intermittent, but has become more severe recently. And then upon researching on their own, Sarah's parents decide that they want her seen by a nephrologist. And we'll go back to this case in just a few minutes. But first, we'll talk a little bit more about primary hyperoxaluria, and we'll start with epidemiology. There are 3 known types of primary hyperoxaluria. And so PH1 is primary hyperoxaluria type 1, as Dr. Liskey mentioned earlier. It's an autosomal recessive disease resulting from mutations in a liver enzyme called alanine glyoxylate aminotransferase, or AGT for short. And on the next slide, we'll talk about the activity of this enzyme. The estimated prevalence of primary hyperoxaluria is less than 3 per 1 million people, and 80% of patients with primary hyperoxaluria will have PH type 1. PH type 1 is also the most severe type of the primary hyperoxalurias. The majority of patients with PH1 will reach end-stage kidney disease by young adulthood, and later we'll show you a graph demonstrating this. And so here is a diagram of alanine glyoxylate aminotransferase activity in the hepatocyte. And so you can see on the figure on the right, in the peroxisome of a hepatocyte, alanine glyoxylate aminotransferase catabolizes glyoxylate to glycine. And so when this enzyme activity is either reduced or absent altogether, there is a buildup of glyoxylate in the hepatocyte, including the cytosol of the cell, and where another enzyme called lactate dehydrogenase can convert this glyoxylate into oxalate. And that's really the main pathophysiology findings in patients with primary hyperoxaluria, is this overproduction of hepatic oxalate production. And the kidneys are responsible for excreting this oxalate, and where it can form, of course, kidney stones. Oxalate readily binds to calcium to form stones, but also it can deposit in the kidney tissue itself, which is called nephrocalcinosis. And unfortunately, when patients over time do develop advanced chronic kidney disease, the kidney can no longer handle this hepatic oxalate overproduction, and the oxalate can end up in the blood and deposit in other organs, such as the bone, heart, eyes, and other organs. And this is a term called oxalosis. And here's a graph of demonstrating renal survival over time, year post-diagnosis of PH1. And you can see, and when you can compare PH1 versus PH2 and PH3, that PH1 results in advanced chronic kidney disease much more readily than the other types of primary hyperoxaluria. So PH1 presentation, symptom onset can ensue in infancy and all the way up even into late adulthood. For patients who present in early childhood or adolescence, nephrocalcinosis affects about 10% of these patients. And the majority of these patients will also have symptomatic kidney stones and eventual chronic kidney disease. Adults typically present with recurrent kidney stones and mild to moderate chronic kidney disease, but unfortunately, sometimes they're not diagnosed until they've already developed end-stage kidney disease. The diagnosis of PH1, we'll talk about here in the next couple of slides. We have a diagnostic algorithm. As mentioned earlier, about greater than 50% of patients have kidney failure or advanced chronic kidney disease at the time of diagnosis. You should consider PH1 in any child with a kidney stone event, any child or adult with nephrocalcinosis or unexplained chronic kidney disease. Patients with primary hyperoxaluria type 1 typically have higher urinary oxalate excretion levels than those with secondary hyperoxaluria. An example with a patient who might develop secondary hyperoxaluria could be a patient who's underwent gastric bypass surgery. And a definitive diagnosis is achieved by genetic testing. And so here's a diagnostic algorithm that could be helpful for diagnosing PH type 1. On the left side here, we have patients with normal kidney function. And then on the right side, we have patients who have advanced chronic kidney disease. And in patients with normal kidney function, you might suspect a PH type 1 in a patient who is a child who's had a kidney stone event, and a child or an adult who has nephrocalcinosis and or recurrent calcium oxalate kidney stones, and in patients with a family history of primary hyperoxaluria. And the test of choice here to start is a 24-hour urine oxalate level. And then we'll shift over here to the patients with advanced chronic kidney disease who you also suspect might have primary hyperoxaluria type 1. Maybe they have recurrent calcium oxalate stones. Maybe they have nephrocalcinosis. Here the tests of choice are a 24-hour urine oxalate level, but also a plasma oxalate level. And this goes back to what we discussed earlier, which is when there is a hepatic overproduction of oxalate and patients develop advanced chronic kidney disease, the kidney can no longer keep up with that overproduction of oxalate. It cannot excrete it readily, and it can build up in the plasma, deposit in other organs, again, like the bone. And here is where you might see an elevated plasma oxalate level in these patients. This lab is also particularly helpful because when elevated, it might dictate treatment choices, such as early initiation of hemodialysis compared to other patients with advanced chronic kidney disease, who you might wait longer to start hemodialysis in. And the role of hemodialysis in these patients is actually to prevent oxalosis. And here I'm just going to point out, going back to the patients with normal kidney function, that you find an elevated 24-hour urine oxalate level. There are some other urinary labs that you can check. For instance, elevated urinary glycolate levels could be suspicious for primary hyperoxaluria type 1. Elevated urinary L-glycerate levels could be suspicious for primary hyperoxaluria type 2. And then elevated 4-hydroxy-2-oxoglutarate levels would be suspicious for primary hyperoxaluria type 3. But as discussed earlier, the role of genetic testing is very valuable in these cases, perhaps when you already have an elevated 24-hour urine oxalate level and your suspicion for pH is already high. You could also proceed with genetic testing at this step as well. And so here I'll focus in on some results you might see for patients who you had a suspicion for primary hyperoxaluria. And so in PH type 1, you will see a pathogenic mutation in gene AGXT. In PH type 2, you will see a pathogenic mutation in a gene glyoxylate reductase, hydroxypyruvate reductase. And then at PH type 3, you would see a mutation in gene 4-hydroxy-2-oxoglutarate aldolase. So let's take a look at a patient with PH1 who will describe his journey to diagnosis with PH and the effect it's had on his life.
So my First symptoms were kidney stones at age 3, which no one really thought was too abnormal. And then I probably passed stones without any intervention. I had surgery at 3. And then I probably passed stones without intervention until I was 14. And then from 14 years on, I have never been stone free. And I've probably averaged 2 procedures a year for kidney stones since 14. So, yeah, you're like the circus animal. All your friends know you've had kidney stones and you missed a lot of school and, due to surgeries, or you have to leave in the middle of the day because you have an attack or, so those are, but you just learn to live with it. It really, after so many years of it, it's not, it just is what it is. And the number one thing is kidney stones hurt. And when kidney stones hurt, everybody kind of, and I'm talking kind of chronic kidney stones, which patients have chronic kidney stones most of the time. I'm not talking about the renal colic, the, rolling on the floor, can't stand it kind of pain. The way I describe it is like if a normal person just kind of has a bad headache, something they would take Advil for, just kind of move that around to your back and just do that 24 hours a day, 7 days a week. That's been my pain for 25, 30 years. So I'm 51. I'll be 51 right now. And I just got diagnosed in January. So 50 years. Yeah. So I self-diagnosed finally in like January, where I was just kind of Googling, why does your body produce oxalate? Because I knew that there had to be a reason. And I had Googled it before, I just never found anything. And I came across OHF, the Oxalosis and Hyperoxaluria Foundation. And they had some great information on PH1. And I remember waking my wife up and saying, hey, I think this is it. And she kind of rolled over and went back to bed because this has been ongoing for so long. But long story short, I took it to my doctor, my nephrologist, actually called OHF. They got me in touch with one of the drug companies who does free testing, genetic testing. They went to my nephrologist. My nephrologist, the front office actually refused to do the treatment or the test. They said they didn't have access to FedEx to deliver it. They said that they didn't do the genetic testing. So it was like a month delay trying to fight with them to get them to do it. And I finally went to my PCP, who knows nothing about and neither did my nephrologist for that, but she helped me through to get the diagnosis. And within a month, the test came back positive.
As you just heard, the diagnosis of PH1 can often be very delayed, resulting in a significant impact on patients' lives. So we'll return to Sarah, the case that we discussed at the beginning of the presentation. So Sarah's initial workup shows significant hematuria, mild proteinuria, and presence of calcium oxalate monohydrate crystals. She has an elevated creatinine at 1.2. She has a normal serum calcium, a low serum bicarbonate level at 18, and her abdominal ultrasound shows bilateral nephrocalcinosis and multiple kidney stones in the right kidney. Her 24-hour urine collection shows an elevated urine oxalate level at 150 milligrams per day, which is markedly elevated. A typical reference ranges would be less than 40 milligrams per day as being normal. She has normal urinary calcium levels and low urinary citrate levels. Due to your suspicion for primary hyperoxaluria in this patient who's had kidney stones since age 5, with these associated lab and imaging findings, you decide to pursue genetic testing, and you find a pathogenic mutation in the AGXT gene, which confirms the diagnosis of primary hyperoxaluria type 1. And so here, before we turn it over to Dr. Lusky, we decided we want to talk about Sarah's case and perhaps how it might have been handled differently and could or should she have been referred to nephrology care earlier.
Well, a couple of things. I think that she had several kidney stone events when she was 2 and 5 years old. And from the case as it was presented, really no specific work was done. And now she's 11. And now she has, some chronic kidney disease as well as nephrocalcinosis on her ultrasound. So, I think if treatment had been started earlier, if she'd had the workup, 5 or so years ago, I think that perhaps some of this nephrocalcinosis or even the chronic kidney disease could have been prevented. Maybe she wouldn't have had as many issues with stones and the infections that she had more recently. So I think, as you said in that algorithm, it really should trigger a workup if you see these things in a very young kid like her.
Thanks, Dr. Husky. I agree. And we'll turn it over to you for to discuss updated guidance and evidence for managing patients with PH1.
Great. Thank you very much. So I'm going to go through a couple of the traditional things we've done for treatment for standard of care for patients with PH type 1. So number one, for these patients, as well as really any patients with kidney stones, is hyperhydration, which really just means high fluid intake. So this is defined as more than 3 liters per day and normalized to 1.73 meters squared of body surface area if it's a younger individual. In general, you would start this in any patient with kidney stones, but even if you had a high urine oxalate and you didn't yet know if they had type 1 PH, probably you should start this right away. The guidelines for pH may even be a little higher than this traditional number, so 3 to 4 liters per day in adults, and then 2 to 3 liters per meter squared in children. If it is a young child, you may need to do a gastrostomy tube, which is obviously going to be fairly invasive. Even if patients do have good fluid compliance with this regimen, we can still progress to kidney failure. And it's well known that we've all seen cases where patients have mild dehydration from some sort of GI illness or other reasons, and this can lead to acute kidney injury, and this can be irreversible. So in that circumstance, you might even consider whether or not they should get intravenous fluids if they're not able to maintain this oral hydration regimen. The second hallmark of our treatment would be citrate. So this is also something we use a lot of in a lot of patients with kidney stone disease in general. It is a crystallization inhibitor. So if we give oral citrate, this will directly and indirectly increase the amount of citrate that you excrete in the urine. And then this combined with crystals and calcium to prevent calcium oxalate crystallization. The dosing prescription is shown there, 0.1 to 0.15 grams per kilogram for patients with preserved kidney function. If they do have advanced chronic kidney disease, probably a GFR less than 30 mils per minute, you might want to think about if you're feeling comfortable giving that patient potassium or not because of the chronic kidney disease. The other part of our standard armamentarium for many decades has been pyridoxine or vitamin B6. So specific genetic changes that cause PH type 1 might be responsive to PH1 either completely or partially. So it is recommended that all PH1 patients should have an empiric trial of pyridoxine to see if their urine oxalate falls or not. So this basically, you would have a baseline 24-hour urinary oxalate excretion, put them on pyridoxine for probably a month or so, and then repeat this and see if the urinary oxalate excretion changed or not. The official definition for partial responsiveness would be over a 30% decrease in this urinary oxalate excretion. Fully responsive would be normalization. And it's important to recognize that this is a high dose, not just a standard amount you might get in a health food store. So it's 5 to 10 milligrams per kilogram is the amount of pyridoxine you would need to give in PH type 1. Some of the genetic testing, there's a very specific mutation that we know should be either partially or completely responsive, and several others that there's pretty good evidence that they will be at least partially responsive, but I don't think we know all of the patients that will respond. So even if you do have genetic results, we would go ahead and do the pyridoxine responsive testing in everybody. So now I'm going to go on to a little bit about RNA interference agents. So this is similar to the slide we saw previously, showing the pathways of oxalate generation, and I won't go through that in detail again, but Just to point out that the two targets that might be helpful for PH type 1 here would be labeled here GO, which is the enzyme glycolate oxidase that converts glycolate to glyoxylate in the peroxisome. That is the target for lumasiran. And then LDH over there, which would convert glyoxylate to oxalate in the cytosol probably. This also should be effective for type 1 PH, and there is some hope that it might also be effective in type 2 as well as type 3 PH, which we're not talking about today. That is the target of the second agent that's currently available on nedosiran. So lumasiran is targets the mRNA that's encoded by HAO1 gene, which includes glycolate oxidase we saw on the previous slide. It's a small and interfering RNA that will block this step. It has been approved as an orphan drug for the treatment of PH type 1 for all age groups, and then the dosing of this would be based on the body weight in infants in particular. This is the phase 3 ILLUMINATE-A study. That was the important study for this product. Patients were over 6 years of age and had to have preserved kidney function, defined as over 30 mils per minute of eGFR. Patients were randomized 2-to-1 for active product lumasiran versus placebo for the first 6 months. The lumasiran was dosed 3 milligrams per kilogram every month for 3 months, and then they're maintained every 3 months thereafter. At the end of that 6-month period, then they were, the patients that had received the placebo also were switched over to lumasiran for the next 6 months. And then after that 6-month period, everybody continued on lumasiran thereafter for long-term follow-up. This is the important slide showing the key outcome measure, which was urinary oxalate excretion. Patients that got placebo are in the red line, and then the patients that initially received lumasiran are in the bluer line. And you can see in the first 6 months that the patients that got the lumasiran, their urinary oxalate excretion dropped by about 60 to 70%. And then after that, the patients that were rolled over from placebo to lumasiran also dropped a similar amount, and then it's been maintained out here to 36 months. So it seems to be a pretty durable effect as well. The other things that I've looked at in ILLUMINATE-A were the kidney stone events. So shown here is the baseline before patients were started on the lumasiran, and then the follow-up periods every 6 months after that. And in general, it appears that the kidney stone event rates are somewhat lower after patients are on the lumasiran versus prior. Although I would caution that we know from history that there is this stone clinic effect, and looking at it this way is not really definitive, but certainly it seems like there are sustained and somewhat lower stone event rates after patients are on lumasiran. As far as side effects, really nothing really stands out other than injection site reactions. So this is an injectable product, so there have been a certain number of patients that have these sort of injection site reactions, which are relatively mild, have not necessitated anyone discontinuing the therapy in the studies to date. All the other things here are thought to be not related to the study drug and seem to be equal between placebo and lumasiran treatment. ILLUMINATE-B was a follow-up study that was done in younger children. So in this case, patients less than 6 years old were eligible. And shown here is, again, the key outcome of urinary oxalate excretion. Because these were younger individuals, we were looking at random urines as opposed to 24-hour urines, and then it's normalized to creatinine. The percentage drop in this, however, was very similar to the patients in the ILLUMINATE-A. So it's about a 60 to 70% drop in the urinary oxalate excretion in the children, regardless of the age. So here they're shown in different increments of body size, but basically the effect was similar in all infants on these random urines out here to 12 months. In this study, they also looked again at nephrocalcinosis as well as kidney stone events. In this case, the kidney stone events, which are in the lower right, were similar before patients were started on treatment versus the time periods afterwards. The nephrocalcinosis No patients seemed to worsen after they were started on lumasiran in ILLUMINATE-B, and there is some hint that there may be some improvement in some, but I think the word is still to be established on this, whether or not there will be the potential for resolution of nephrocalcinosis over a prolonged period of time if the urinary oxalate excretion is dropped as much as we think it seems to be with ILLUMINATE-B. ILLUMINATE-C was the chronic kidney disease study for lumasiran. So in this case, there were two cohorts, one patients with an estimated GFR less than 45 but not on dialysis, and then cohort B would be patients that had chronic kidney disease and kidney failure and were on hemodialysis. There was a 6-month primary analysis period. All the patients were on lumasiran, again, loaded per the standard protocol monthly times 3 and then every 3 months thereafter. And then there has been a long 54-month extension period after that. This slide really shows the key outcome here. Since these patients do have kidney failure, the plasma oxalate is the more pertinent outcome, especially the patients on dialysis. We really can't look at the urinary oxalate excretion. And in both cohorts, the cohort A and B, the plasma oxalate did fall substantially from 60 to about 30 in the cohort A not on dialysis, and then from a little bit over 100 to 60 or so in the cohort B that was on hemodialysis. So it does seem like there's a significant improvement in plasma oxalate, which in turn reflects what's going on with hepatic oxalate generation in these patients. Bonafide is a long-term follow-up study, so it's prospective observational. I'm currently recruiting with a target of 200 estimated enrollment, and the goal is to really describe the natural course of patients with PH1 over time, and then to evaluate the long-term efficacy and safety of lumasiran in the subgroup of these 200 that are on lumasiran over the time period of the study. Nedosiran is the second small inhibitory RNA that's now available for treatment of patients with PH type 1. This one targets hepatic LDHA, the enzyme that mediates oxalate production in all subtypes of PH, we think. This is given a little differently than lumasiran. It's once monthly subcutaneous throughout whenever the patients are on it. This has been approved from 2023 onwards for adults over or children over age 9 and adults, and with preserved eGFR over 30. And then the dosing is also based on the body size. This is the study design for PHYOX2, which was the key study for approval of this agent. The primary endpoint was once again urinary oxalate excretion. In this case, they were looking at the percent change from baseline in 24 urinary oxalate excretion. Patients were randomized 2-to-1 between placebo and active drug here, nedosiran. In this case, all patients were either on placebo or nedosiran for the full 6-month period. And this is really showing the way that they expressed their primary endpoint in the PHYOX2 study was the area under the curve of urinary oxalate excretion. And the placebo arm is in the orange, and the treatment arm is in the blue. And basically, there was about a 40% change in the area under the curve of urinary oxalate excretion over the time of the treatment. And there was no change in the placebo group. So pretty significant fall in the urinary oxalate excretion out to 6 months with nedosiran. Okay, so at this point, let's go back to our patient who will describe his experience with treatment for PH1 and his advice for patients newly diagnosed with PH1.
Once I got the diagnosis and got with the Mayo Clinic with Dr. Liskey, who recognized right away that there's a certain genetic, I guess an allele as they call it, that PH1 is my allele is partially receptive to B6. So I'm on very, very high doses of B6, like 700 milligrams a day. So there's 2 approved treatments for it. I had already kind of studied and researched both of them. I didn't really have a preference between the 2. It was kind of what I could get first. One of them provided quite a bit of support to help me navigate and help my PCP navigate the process of getting this approved, which took about 3.5 months to jump through all the hoops. And I'm now on my 4th month of treatment. It's done at an infusion center. It is a once-a-month injection with a 3-month loading dose, and then it goes quarterly after that. I'm receiving my first quarterly dose tomorrow. I've experienced no side effects. It's a sub-Q injection. It burns a little bit at the site for maybe 10 minutes, but after that, it's don't even know you had it. And so far, my oxalate in my 24-hour urine has been reduced by about 40%. So a pretty significant. I'm almost to normal oxalate production, or at least on the high end of the normal scale, which I've never been anywhere close to. But my advice to anyone is be your own advocate with this, because a lot of people view it as very rare. And if you're treating a patient that has chronic stones and you don't know what it is, obviously there's more to it a lot of times than just hydration and food or diet. I would say that just kind of listen to your patients, and if they have a chronic history, especially from what I've learned, starting as a child or a teen, the ears might go up a little more on that. If they've had lots and lots of stones, high urine oxalate, and started early with stones, it's worth the cheek swab to get the genetic test.
All right. So at this point, I thought we would go through a couple of bullet points describing some of the complexities in PH1 now that we do have 2 potential treatments in addition to our standard of care. So number 1 would be the routine follow-up in patients with PH1 and CKD grade 4 or 5. Typically, these patients, even if they're not yet on dialysis, we think they're at high risk for progressive of chronic kidney disease. Certainly, that's what some of our studies have shown observationally, that patients often will go to kidney failure pretty quickly. We want to look at their plasma oxalates pretty frequently, at least every 12 months, and probably more often than that. Renal imaging is probably going to be important in these patients as well, at least yearly, to look for stones or nephrocalcinosis. I don't know if Dr. Briggeman has any thoughts about that.
Yeah, I agree with the yearly imaging, and I think either ultrasound or CT would be appropriate. And again, it would be CT without contrast.
Yep, and again, the plasma oxalate, once it gets over 30 or so, we think that the risk of ongoing oxalosis starts to increase a lot. So oftentimes, which is down there on the bottom, dialysis might be needed for patients with PH, even if they aren't yet meeting the classic criteria for initiating dialysis with uremia or other symptoms. So we would have an earlier threshold for starting PH1 patients on dialysis compared to your routine chronic kidney disease patient. The bullet 2 there would be related to kidney transplant. So I think this is an ongoing area of interest, whether or not if patients have substantial reductions in their plasma oxalate that are on dialysis with PH1 when they're being treated one of these RNAi treatments, or if they were on vitamin B6 and were fully responsive, would they be able to get a kidney transplant alone versus the standard of care, which has been a liver kidney transplant, the liver part, to replace the liver enzyme that is abnormal in PH type 1. I know there are numerous case reports of this now in the literature suggesting that this can be done. And I think this will be an ongoing area of great interest in the field.
No, I think, just it's something very exciting to think about patients, perhaps as we gain more information, as you allude to, multiple case reports and hopefully more future advanced studies, but where patients might be able to avoid the liver transplant and only have the kidney, especially with the associated morbidity and mortality with the liver transplant itself. So it's something really exciting to think about, but I agree with you. We still have a little ways to go to determine if and when that would be feasible and in what type of patient.
Yeah, and the real reason to think about this is, liver transplant's a much bigger procedure than just a kidney transplant. So if we can avoid that, we would obviously like to, and the patients would as well. And then this third bullet, it says RNAi therapy is recommended for patients with suspected PH1 with CKD5 even while awaiting genetic confirmation. I mean, I think certainly that's reasonable. I think practically speaking, I'm not sure that this would really happen, at least in my practice setting. I think we get our genetic results probably in a month now at the most. And when you think about the logistics of starting someone on RNAi, and probably you need the genetics even to get it approved, and it takes a while to get it approved even when you have the genetics. So I think in theory this makes sense, but I'm not sure it would happen in practice.
I agree. The timing of the genetic testing is seen even in a couple of weeks. In some cases come back, and as you alluded to, the approval of the agent and the paperwork associated with it can take much longer than that. So I agree, it's a nice thought, but not sure how practical.
Great. And we already talked about patients on dialysis, the last one there. So with that, I think that ends our discussion for today. Thanks again to Dr. Briegemann for his insights and expertise. We hope that you found this activity informative and useful for your practice, and thanks everybody for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Alnylam Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/EZY860.